This is Professor Abdullah Hamad from Alexandria, Egypt. I will present a case of total hip replacement in an adolescent female with severe post-traumatic acetabular bone loss. We received a 15-year-old female with a history of RTA at 2024. She sustained a severe acetabular injury, a posterior fracture dislocation, and was initially managed by inadequate open reduction internal fixation at another center. This was the post-operative X-ray. Obviously, the fixation is inadequate, and the patient had ongoing pain and progressive shortening of her left leg, and she was presented again to the same center, where they decided to remove the internal fixation and collect cultures to clear the possibility of deep infection. We received the young girl 1.5 years after the first surgery. She was presented to us by sciatic nerve injury, malpositioned surgical scar toward more posterior orientation, denoting difficulty in surgical exposure, and severe acetabular bone loss apart from the migration of the femoral head more than 3 centimeters from the teardrop. There is no other lysis at the ilioschial line or cochlear line, means this is Bobrovsky 3A to B subtype. This is the both hips AP showing migration of the femoral head up and in and shortening of the lower limb. The CT scan showing affection mainly of the posterior column with loss of part of the posterior wall. However, the anterior column was intact and the femoral head was still integrally okay, but with cartilage loss. So we studied the femoral head for the signs of EVN or structural damage to know if the head is a possible source for a good graft or not. And we decided that the femoral head could be used as a biological reconstruction, especially in the very young lady, which is only, again, 15 years old. The coronal view of the CT shows migration of the femoral head and loss of the medial part of the posterior column, and the axial cuts showing the damage of the posterior wall and major part of the posterior column. This is the gait which was recorded preoperatively. The patient had a Trendelenburg and some antalgic gait, and she was not capable of free movement, especially with longer distance. So we decided to do an acetabular reconstruction using the femoral head as an autologous structural bone graft. This is the scar of the previous surgery, which was not utilized in such case due to malposition of the scar. And after standard posterior approach, we exposed the acetabulum, and the defect is obviously posterior superior. This is the native acetabulum, and this is the defect posterior superior. So we hugged the anterior column and the tail, transverse acetabular ligament, to do progressive reaming at the native acetabulum. So this will help in decreasing the size of the defect. We are very cautious in medial reaming due to deficient medial wall from the previous CT. Once we reach the maximum diameter, which is determined by the distance between the anterior wall and the remaining part of the posterior inferior wall, the trial of a 50 cup was put to study the remaining part of the defect initial stability of the trial was okay, was holding, but obviously the cup will need a posterior superior support. So we used the femoral head in a standard fashion, which is 7 graft, to replace the deficient part of the posterior column and posterior wall. This is the graft after preparation. We turn it upside down, so the femoral head will be hanging to the acetabular cavity, and this is just completion of the reaming of the native acetabulum. So the graft is turned upside down, so the neck part will be used for the fixation because it has more hard bone, and the head will hang to the acetabular cavity. So after fixation, we'll do reaming at the periphery to have a structural integrity of the native acetabulum together with the graft, creating a hemispherical structure to hold the cup. The graft is initially fixed by K-wire. The screws should be oriented towards sacroiliac joint. You use both orientation, and you can use tactile exposure with your fingers through the greater sciatic notch to exclude premature penetration of the screw to the notch. So the screw will remain in the cortical corridor towards the sacroiliac joint. Usually the screw length is from 60 to 70 millimeters. This is the first screw. And this is just after completion of the second screw. So now the graft is holding. So we ream the periphery of the native acetabulum to the graft. Usually we ream to the size before the cup that we need to insert. So the graft is reamed with the reamer up to 48 and leave the 2 millimeters for a more press fit. But one should avoid vigorous hammering to avoid fracture of the graft, which is now very precious piece of bone, because it's an autograft which will help more in osteointegration for such young girl. One should be sure that the floor of the acetabulum is clear, so you avoid lateralization of the cup. So now the reamer is okay. Start to engage to the graft. So to the right hand side is the anterior part of the acetabulum, and to your left hand side is the posterior superior part at the graft side. This is the 50 cup, multi-hole cup. So the cup is hammered gently and should be covered by the edge of the graft, but not too deep, not to avoid the structural support of the graft. Then the screws are tightened over the cup to have more compression. The handle is removed. The stability is checked. Cup is then augmented by fixation of the screws at the safe zone. And then the polyethylene liner with a high posterior wall. is inserted. The femoral preparation is done as per routine, and after completion of the femoral preparation and trialing, the ceramic head is inserted and the reduction is okay. Now this is the final check for the offset, stability, and leg length. Sciatic nerve was freed from any fibrous tissue attached in order to have better outcome for the sciatic nerve injury. It is sciatic nerve after complete neurolysis, and actually the patient experienced immediate improvement after sciatic nerve neurolysis. This is the post-operative X-ray showing adequate orientation of both components with restoration of the leg length, good orientation of the screws towards the hard part of the acetabulum, which is the sciatic buttress towards the sacroiliac joint. And this is the lateral X-ray showing good orientation of the screws of the graft and the cup. And the patient had started early weight bearing just after fixation of the cup. And this is only 1 month post-operative. Thank you.